In acute myeloid leukemia, the field is really moving more and more toward genetic profiling. That is, identifying specific mutations which occur in a variety of hematologic malignancies, particularly acute myeloid leukemia and acute lymphoblastic leukemia. And there was a very interesting study conducted at the MD Anderson Cancer Center in Houston, which was designed to determine how often the identification of certain genetic mutations could influence treatment decisions and outcome. And in a cohort of patients, some newly diagnosed with AML, some relapsed and refractory, 77% of patients had an identifiable mutation, which many of which went on to influence treatment decisions and outcome. Many patients were treated on a clinical trial, some were treated off trial, but in about 30% or so of patients, the identification of a specific mutation actually influenced treatment decision. Drug discovery is another major area of research in the area of both acute myeloid leukemia and acute lymphoblastic leukemia. And at the meeting, there were two sort of updates. One was with the IDH1 inhibitor ivosidenib, and the other was with the combination of venetoclax plus one of the hypomethylating agents, either azacitidine or decitabine. Much has been presented already regarding the IDH2 mutation inhibitor, enasidenib, but at this conference, the results of a large phase 1 study of ivosidenib, the IDH1 mutation inhibitor, were presented with very encouraging results in relapsed and refractory acute myeloid leukemia. The overall complete remission rate was about 20% or so, 24% I think to be precise, and the overall response rate, including other response categories, was about 42%, so quite encouraging in patients with relapsed and refractory IDH1 mutated AML. In addition, the drug, the BCL2 inhibitor, venetoclax, when combined with either hypomethylating agent, azacitidine or decitabine, or low-dose cytarabine, has been presented at several other meetings and the results of which are very, very encouraging. At this meeting, the results of patients over 65 or older, with untreated AML, ivosidenib we talked about a minute ago was relapsed refractory AML. These are patients with untreated AML. And they were treated with a combination of the BCL2 inhibitor venetoclax plus either hypomethylating agent, azacitidine, or decitabine. And the results are really spectacular, particularly given the fact these are older adults. The overall response rates were very high, in the 60 to 75% range, and the complete remission rate was also quite high, in the 30 to 40% remission rate. And most encouraging was the minimal residual disease negativity rate, which was quite high for a combination of therapies for patients with untreated AML, particularly older adults. I think those were the main highlights in the area of AML. In the area of ALL, there were several interesting abstracts. In ALL, there have been three major, I would say, key breakthroughs in the last couple of years. Number one, the identification that adolescent and young adults may be best treated on a pediatric-based protocol. The second is the development of new agents, particularly blinatumomab and inotuzumab and CAR T-cell therapy. And the third area is the identification of new genetic subtypes, particularly the Philadelphia chromosome-like disease. And several abstracts were presented at the ASCO meeting, and we will talk about at this meeting. The first has to do with the question of whether you can treat patients with blinatumomab before CAR T-cell therapy. They both involve manipulation of T cells. Blinatumomab is a bispecific T-cell engaging antibody, which is an anti-CD19 and an anti-CD3. And the question is, can you give patients blinatumomab followed by CAR T-cells? In an abstract presented at the ASCO meeting, it was shown, well documented, that there is no hazard by treating patients with blinatumomab before inotuzumab, before CAR T-cell therapy. And a second interesting abstract at ASCO that we're going to discuss here this afternoon concerns the immunoconjugate drug inotuzumab. Inotuzumab is another form of immunotherapy, and it's a immunoconjugate. It's really two drugs in a way. It's an anti-CD22 monoclonal antibody, and it's linked to a very, very potent toxin called calicheamycin, the same toxin involved in another antibody for AML called gemtuzumab ozogamycin. This is inotuzumab. And previous randomized studies have shown that when inotuzumab is compared prospectively to salvage chemotherapy for patients with relapsed ALL, acute lymphoblastic leukemia, patients fared much better if they received inotuzumab. In this abstract presented at ASCO meeting, the question of tumor burden in response to inotuzumab was raised. In other words, is inotuzumab less effective in patients that have a high tumor burden? And in this abstract, patients who had relapsed and refractory acute lymphoblastic leukemia were divided by their tumor burden, the percentage of blasts in the bone marrow, whether they had less than 50% blasts, 50 to 90%, or greater than 90%. So low, medium, and high tumor burden or blast percentage. And the results of the abstract showed that tumor burden, in fact, did not influence outcome. And in fact, the patients that seemed to benefit the most were those patients that had a high tumor burden, documenting that this drug is very effective in those patients. I think those were the two major abstracts concerning adult acute lymphoblastic leukemia.